I am extremely pleased and happy to participate in this excellent meeting on this forum, especially organized by Omnicuris. And I am able to see Dr. Ravi Shankar and Ashish. So I am very happy to introduce Dr. Ravi Shankar, an eminent gastroenterologist and also organizing secretary, Indian Society of Gastroenterology, Telangana chapter, and also Ashish Kumar Jha. He is ex-secretary of Indian Society of Gastroenterology, Bihar and Jharkhand chapter. Today we are discussing about one of the chronic common diseases called celiac disease. It is a chronic immune-mediated small intestinal gluten-sensitive enteropathy, and that has got a strong genetic predisposition, especially with the HLA DQ2 and DQ8 presence. So it presents in a myriad and multitude ways. A number of presentations are there for celiac disease, but the exact problem starts in the small intestine upon gluten exposure, which is immune mediated. It is a sort of autoimmune disease where we know the exact cause, that is the gluten, and it has got effects on the multiple systems of the body like endocrine system, hematological system, hepatic system, and many systems, especially musculoskeletal and cerebrovascular nervous system and all. So now our friends are going to deal extensively about the various manifestations of celiac disease and the challenges we come across in the celiac disease and the epidemiology also, because celiac disease is very frequent in the North Indian subcontinent of this country, especially North Punjab especially has got very high incidence of celiac disease. But because of this globalization, modernization, industrialization and migration of people from one place to another place, so even we are having many North Indians who have got this gluten sensitive enteropathy, especially Hyderabad is the destination for all the people in the world, especially it is called city of destination. So many North Indians are there. They will be coming across some cases of celiac disease, but it is very common in North India, as well as it is present everywhere in the world, more so in the European countries and also in the United States. So now I invite Dr. Ravi Shankar to present his slides and speak about the celiac disease. Yeah.
My senior and a good friend, and Ashish, thank you so much for giving me this opportunity, all of you. And of course, the ISG for giving us and giving me this opportunity. The celiac disease as such, as Dr. Shankar Sharma said, is very common in the north and parts of Europe and America, but somehow the disease is less common in south. There is one study which says that 0.1% of the people have this serology positive in South India. So it is about significantly less common compared to north of India. So in fact, in practice, we haven't been seeing cases of celiac disease. Some could be missed because of the varied presentation, and some may not be presenting to the gastroenterologist. But the classical or the typical cases, as Shankar Sharma has said, even those are not common. I will tell one or two introductory words about the celiac disease, which is a common disease in north of India. And the disease presents typically with intestinal malabsorption, and the patients are diagnosed after a positive serological test and typical pathology after a duodenal biopsy that is performed by endoscopy. So these patients have varied manifestations. Though the simplest presentation is the malabsorption, these patients have a variety of symptoms, and because it is autoimmune disease, a lot of autoimmune features are present, and the disease goes on for several years to come, and patients may develop several comorbid conditions. So what I will do is discuss about the various clinical features of the celiac disease. So in this slide, we are able to see that 27% of the patients have classical celiac disease presentation in the form of diarrhea, weight loss, and malabsorption. And non-classical presentation is seen in about 52%, that is constipation, anemia, osteoporosis, transaminase elevation, certain neurological disorders, and dermatitis herpetiformis, which is a common skin condition related to celiac disease. 21% of the patients may not be having any symptoms. So, what we have been understanding is the classical symptoms, but maybe we are missing a lot of non-classical celiac disease. Here there are two short forms, that is OACD, which is ongoing active celiac disease, and ACDC, associated celiac disease conditions. So when there is ongoing active celiac disease, it is usually due to continuous gluten exposure or sometimes a slow response or non-response to gluten withdrawal. There may also be a condition like which we'll be discussing, that is a refractory celiac disease. To confuse the issue, the celiac disease may be associated with a number of other gastrointestinal conditions which mimic celiac disease and which may be falling in the various differential diagnosis of celiac disease. So if these diseases are associated with celiac disease, one could find difficulty in differentiating these conditions. So these diseases could be microscopic colitis, irritable bowel syndrome, small intestinal bacterial overgrowth, lactose fructose intolerance, diverticular disease of the colon, Crohn's disease, pancreatic insufficiency, and drug-induced enteropathy. So these disorders may be associated with the celiac disease and cause further confusion in the clinical picture. So various comorbidities of the celiac disease can be brought out under various heads like extraintestinal features, diseases associated with celiac disease, unresponsive celiac disease, and malignancy associated with celiac disease. So extraintestinal features, we can say that among the cutaneous features, we may have dermatitis herpetiformis, follicular keratosis. Among the endocrinological disorders, we see in the as extraintestinal features short stature, secondary hyperparathyroidism, infertility, amenorrhea. Hematological manifestations could be anemia or hyposplenism, which can be diagnosed by ultrasound. Hepatic manifestations are liver enzyme elevation, sometimes rarely autoimmune hepatitis, and probably this liver enzyme elevation could be a part of lymphocytic hepatitis. Any patient who has liver enzyme elevation and no obvious cause is present, then one should think about celiac disease. Neurological manifestations could be peripheral neuropathy, ataxia, a syndrome called CEC, which is celiac disease, epilepsy, and occipital calcifications. There could be seizures and demyelinating lesions. Among the skeletal manifestations, osteopenia, osteoporosis, and osteomalacia could all be present. So we need to consider all these extraintestinal manifestations whenever we think about celiac disease, and there is a need to screen for majority of these problems. So now they were the extraintestinal manifestations. Now this slide deals with the associated disorders with celiac disease. Among the endocrine disorders, there could be Addison's disease, diabetes, hypothyroidism, hyperthyroidism. Among the pulmonary disorders, Bird-Fancius lung, cavitary lung disease, cystic fibrosis, fibrosing alveolitis, sarcoidosis, idiopathic pulmonary hemosiderosis. Among the hematological, autoimmune hemolytic anemia, idiopathic thrombocytopenic purpura, IgA deficiency, and other rare syndromes like Down syndrome, Sjogren's syndrome, pericarditis, and dermatitis herpetiformis. Dermatitis herpetiformis is again a very classical disease that could be associated with CD, or sometimes it is present on its own. So there are certain factors which cause increased morbidity in the course of a patient who has celiac disease. These diseases could be coronary artery disease, cerebrovascular disease, atrial fibrillations, and cardiomyopathy. These disorders are mentioned because these could be increasingly seen in celiac disease. The malignancies are non-Hodgkin's lymphoma, enteropathy associated T-cell lymphoma, and small intestinal adenocarcinoma. These are the malignancies the patients of celiac disease are predisposed. And some of other associations are COPD, bronchial asthma, tuberculosis, and influenza. These disorders may have an increased morbidity compared to the general population. And classical celiac disease with a gluten-free diet, I think everything is going on well. There would not be a problem. But if the disease is unresponsive, then the real issue starts. So these could be seen in adult patients with celiac disease, and these can be categorized into non-responsive celiac disease. Sometimes it is also called slow responders. Then the real problem, that is a refractory celiac disease, which can be of two types, type 1 and type 2. And there is a complication of celiac disease, that is ulcerative jejunouleitis and collagenous sprue. As the names go by, the refractory celiac disease, there is a severer variety. The type 2 is a severer variety, and these patients require a lot of innovative treatment, and sometimes it is very difficult or untreatable. So just to know a few aspects of non-responsive celiac disease and refractory celiac disease, we need to know the difference between the two. The non-responsive celiac disease, basically it is about the symptoms and signs, that is persistence of the symptoms and signs after 6 to 12 months of gluten-free diet. Whereas the definition wise, refractory celiac disease is persistence of the symptoms and also the persistence of small intestinal villus atrophy after 12 months of gluten-free diet. So histology is not taken into consideration in non-responsive, and refractory, it is to be further evaluated by biopsy, and then it is to be labeled as refractory celiac disease. So the non-responsive celiac disease, the common cause could be ongoing gluten exposure, knowingly or unknowingly, and also there could be associated gastrointestinal problems, as we have mentioned in one of the earlier slides, that these patients could be having associated lactose intolerance, SIBO, irritable bowel syndrome, or chronic pancreatitis, or microscopic colitis. They could be causing the symptoms. Whereas the refractory celiac disease is a problematic disease, and this manifests as villus atrophy, and IL-15 is increased in the intestines. These are, as we have said, two types. Type 1 is milder, type 2 is more severe, and fortunately the type 2 disease is less common, and the type 2 disease is an aggressive disease with the presence of abnormal undifferentiated oligoclonal T cells. These are called aberrant T cells for ease. We can call it that the type 2 has got aberrant T cells and type 1 has no aberrant T cells. Type 2 refractory disease is more aggressive and type 1 is mild. And various treatments are suggested. The immunosuppressants are usually given for the type 1 disease. Probably immunosuppressants have no major role in type 2 disease, but other things like continuation of a gluten-free diet, steroids, and monoclonal antibodies like anti-IL-15 are considered in the treatment of type 2 disease. But still, it is a difficult disorder to treat. The condition ulcerative jejunouleitis is rarer but a serious complication of celiac disease. In these patients, as the name goes, there is ulceration of the jejunum and ileum, and this disease should not be confused with Crohn's disease because this is in the setting of a celiac disease. So these patients have weight loss, abdominal pain, and ongoing diarrhea. There is no response to gluten-free diet. So one needs to check up whether gluten-free diet is being followed adequately or not. And then these patients have ulceration strictures, and the presentation is usually by hemorrhage, intestinal obstruction, or perforation. So the disease may progress to lymphoma. So workup requires elaborate workup after going through the basics and basic labs and basic imaging modalities. One needs to subject the patient to various contrast series depending on the patient, and the CT scans and whatever required enteroscopies. Sometimes laparotomy may be needed for treatment and diagnosis. So this ulcerative jejunouleitis is treated by steroids and immunomodulators like azathioprine, and sometimes surgical excision is required. The other complication is the collagenous sprue, which is characterized by subepithelial presence of the collagen, pathologically which should be thicker than 10 microns in the small intestine. And this is refractory to therapy, and usually the presentation is as a non-response to celiac disease, and this disease needs to be diagnosed by biopsy, and then these patients needs to be treated by, again, gluten-free diet, strictly adhering to the diet, and corticosteroids. It is not that collagenous brew, if it is present, the patients definitely will do badly. There are patients who do have good response to corticosteroids. So malignancy are two types, that is the enteropathy associated T cell lymphoma. Usually we see that it is a B cell lymphomas in the intestines and other areas, but in this celiac disease, the complication is T cell lymphoma and sometimes adenocarcinoma. The enteropathy associated T cell lymphoma, which is classical in celiac disease, usually occurs at around 20 to 40 years of Crohn's disease. It is of T cell origin. Usually it is preceded by refractory celiac disease. The presentation could be intestinal bleeding or obstruction. The mesenteric adenopathy may be there, which have cavitation. So this is one of the features, cavitating adenopathy. Prognosis is generally poor, but treatment is with anti-CD30 and chemotherapy. Adenocarcinoma, again, is a rare complication, and the adenocarcinoma is seen usually in the jejunum. It is more common in women. It may not be preceded by refractory celiac disease. The presentation is usually in the form of obstruction, as that is a subacute intestinal obstruction and or anemia. And the diagnosis is usually by imaging and enteroscopy, and treatment is surgical. So dermatitis herpetiformis is a classical disorder that is seen in association with the celiac disease. It may be seen in patients who do not have celiac disease also. The lesions that appear are, as though it is a dermatological condition, we gastroenterologists may have, it's better we also know a little bit about dermatitis herpetiformis, because it could be missed otherwise, or we may have to, if we know this disorder, we can quickly come to a conclusion and then refer appropriately. The papillovesicular lesions, which are symmetric and seen on the extensors extremities, on the buttocks, trunk, neck, and scalp. There are pruritic lesions, and once the vesicles are rubbed off, the itching is relieved. So that means the patients usually scratch off the vesicles and relieve the itch. There is a male predominance, and the skin biopsy shows speckled IgA deposits, and ideally, more than the lesion per se, perilesional skin shows the classical features. So this dermatitis herpetiformis may be a lone disease or associated with enteropathy, as we have already said. So the dominant antigen in dermatitis herpetiformis is type 3 transglutaminase, whereas in celiac disease it is a type 2 TG. There is a differential diagnosis. I think we need not go much into the linear IgA disease, which is considered as a differential diagnosis. And the treatment of dermatitis herpetiformis is, again, gluten-free diet and dapsone. So follow-up visits are very important. I will not go into all the details, because every 6 months to 1 year, the patient needs to be followed up, and follow-up is usually by symptom assessment, certain labs, and also the serological estimation. One need not go after the biopsy as a routine fashion, but biopsy is rarely required. So the reason for not doing the biopsy is also the villi reconstitution may take a longer time. So biopsy is not an essential part of follow-up. So summarizing, the various aspects of celiac disease, that is the extraintestinal manifestations, the various disease associations and complications, needs to be understood for proper understanding of the patient and proper management. And definitely we require all our colleagues in different specialities to take care of the patient, and patient needs appropriate referral to appropriate specialist at an appropriate time. And adherence to the gluten-free diet is the basic backbone of treatment, and there are various complex treatments that are required in a minority of the patients, which includes monoclonal antibodies and specific monoclonal antibodies like IL-15, and in fact sometimes various chemotherapeutic regimens, and advanced endoscopic treatments like enteroscopies, and also surgical techniques like resection of the tumor in patients who have developed a adenocarcinoma in the long-standing celiac disease. Thank you so much.